which was present 5 to 6 times per day, but the consistency of the stools were normal. Menstrual cycle, initially patient used to have a regular menstrual cycles, but now the patient has developed oligomenorrhea. Patient have 2 children, both pregnancies were uneventful. There is a history of hypothyroidism in the mother. In the treatment history, there is no history of any recent drug intake by the patient or any radiation exposure to the neck. So from the history, we are having a patient who is a 40-year-old female who presented with increased appetite, palpitations, intolerance to heat, tremulousness of body and hands, with irritability, anxiety, and increased frequency of stools and oligomenorrhea associated with the recent protrusion of the bilateral eyes. So with these history, uh, these symptoms, they are suggestive of that the patient is having a features of the thyrotoxicosis, and we further proceeded with the examination of the patient. During the examination part, the patient build was thin build. She had an anxious look. The pulse, the patient was having a tachycardia of 120 beats per minute, which was a regular, and the pulse was high volume collapsing pulse without any radio-radial delay and radiofemoral delay. Blood pressure, when it was noted, it was 160 by 60 mm Hg, having a wide pulse pressure was there. Temperature was normal. On general examination, the fine tremors of both the hands were present. Skin was moist, warm, but there was no pretibial mixed edema was seen. Further, on examination of the thyroid gland, on inspection, the thyroid gland was diffusely enlarged. There was no visible scar, pigmentation, or dilated veins. Swelling moves with the deglutition, but it was not moving with the tongue protrusion. Lower border of the swelling was visible. On palpation, it was non-tender, warm to feel, diffusely enlarged, having a firm consistency with smooth surface. There was no fixity to underlying skin. It was mobile. No tracheal, uh, no tracheal deviation was there. No thrill was palpable. On further examination of the thyroid gland, the percussion was done on the manubrium sterni. It was a resonant. Auscultation was done. There was no audible brew was present over the thyroid gland. Further, the examination of eyes was done. On the examination of eyes, there was a wide palpable fissure. There were visible upper and the lower sclera. No chemosis was seen. Certain signs was evident from our examination that the lid lag was present. Loss of wrinkling was there. The patient was not able to converse the eyes and infrequent blinking was present. Systemic examination revealed the patient have S1 and S2 as audible, with systolic murmur was present in the pulmonary area. Respiratory, it was within normal limits. Abdomen was normal limits. Neurological examination demonstrated the patient have brisk reflexes. So the provisional diagnosis that we arrived with these history taking and the examination that the 40-year female having a symptoms of thyrotoxicosis with associated ophthalmic changes. So we arrived at the patient is having a Graves disease with Graves ophthalmopathy.
Nishant, do you have any picture of that patient?
Yes, sir. This one.
Have you shown that eye signs and everything? Do you have that
Yes.
thing?
Eye signs, sir, that is
You
not
didn't have
available,
that
sir.
picture with you. You
No,
didn't
sir.
take
Sorry
pictures
that.
of the eye signs and everything?
Sir, I can
Physical
means picture
examination.
is not there, but I wanted to actually we wanted to explain with ma'am all these things that how we have done it, what special science. So shall I go with this?
Videography is not there. Videography?
No, sir. Videography is not there.
It
So,
would have been better if you have some
Hmm.
real
Clinical examinations.
pictures.
Videography.
Yes. Anyway,
but here, one point regarding that thing, your case is obvious, okay, and these sort of cases are being definitely given in your DNB as well as MD examinations. So some points that you have expressed in your examinations that you say that the lower border of the thyroid swelling is visible. What is the clinical implication of that thing? One. Second, you have said that some bruit is also audible, not audible over the thyroid. You just tell
Yeah.
me what are the two important, these are the two signs that should be seen for and its clinical importance. The lower border of the thyroid, what is its clinical importance? And second is bruit. You just try to explain that.
Okay.
Actually, I
Thank
have
you, sir.
joined from my mobile. Okay.
Okay,
I'm
ma'am.
Dr. Sharmishta. I'm joined from
Okay,
my
okay,
mobile.
please. Most welcome.
Yes,
In
yes.
your place,
I'm
Dr.
extremely
Sarbani was.
sorry for the logistics because
No,
actually
no, okay, okay, okay. It's all right.
working
This thing
minutes
happens.
now.
This thing happens
I'm
to
extremely
anyone.
sorry and I apologize for the problem. But
Okay,
I
okay.
can now interrogate. Thanks very much that
Okay,
you have
please
already
start.
started.
Yes,
Okay.
ma'am.
So
Okay, please start.
little bit I know
Please,
the
please
history
take
and
over.
little bit I have acquired from now. Can I interrogate Dr. Nishant now?
Yeah, definitely. So,
Okay,
Dr. Sharmista,
thank you so much.
Dr.
Okay,
Sharmista,
Dr. Nishant, you have told about some uh, weight loss of the patient. Can you tell me what are the causes of unintentional weight loss? Few causes, if you can tell us.
Yeah. First of all, ma'am, in the Indian setting, we have the most common, we have the infectious causes like tuberculosis. Patient may have underlying HIV or AIDS. Endocrine causes, we have this hyperthyroidism, which can result in the weight loss. Then we have the diabetes mellitus patient. Patient may have some GI disturbances in the form of malabsorption syndromes. They can have patient have underlying malignancies, then which can result in the weight loss, or the patient may have some psychiatric illnesses in which the patient have decreased appetite, or there is anorexia nervosa like symptoms where the patient may have this decreased weight loss, unintentional weight loss.
Okay, so among these things, which you think that in spite of increased appetite, there is weight loss? What are the causes?
Ma'am, in this, ma'am, it will be the thyrotoxicosis symptoms, hyperthyroidism, where the
Anything
appetite
else?
is enhanced, where the appetite is increased. Second is, ma'am, diabetes also.
Yeah,
The patient has,
definitely.
yes, ma'am.
Okay, so
These
you
two.
have mentioned that there is no relevant drug history. So which drug you are thinking of?
Ma'am, either the patient having a features of this hyperthyroidism, patient have either excess intake of iodine drugs, so that can point out. And second, the drugs that are associated with the destruction of the thyroid gland, like amidrone, it is also related with this thyrotoxicosis symptom.
Okay, so actually I have joined through this also. So
So, Mr. I think you proceed to the examination. They all
double.
yeah, they wanted to know
Ma'am,
about the clinical examination done by the Dr. Nishant.
Yeah. So the clinical examination part.
see.
Very important points were
Uh,
raised by Dr. Kormokar.
yeah.
I
By
think
that time, ma'am, sir, I would like to give the answers of the two questions that were asked by the sir. The first question was, what is the significance of when the lower border of the thyroid was not visible? If the thyroid gland having the extension towards in the lower border, means behind the sternum, that is the retrosternal goiter, then there will be difficulty to see the lower border, and it will also will not be able to palpate the lower border in the retrosternal goiters. And the second question sir has asked regarding the brew, if there is an increased vascularity, because in the thyrotoxicosis state, there is a hyperdynamic circulation, so which results in the increased vascularity. So this thyroid brew can be palpable, thyroid brew can be heard, can be auscultated over the thyroid gland due to increased vascularity in this thyrotoxicosis state.
Okay, so what is Pemberton sign?
Pemberton signs, basically the in continuation of this retrosternal goiter thing, ma'am. We ask the patient to raise the arms above the shoulder, and such that they are by the side of their ears, and we ask them to hold it for 1 minute. And after 1 minute, we look for there will be the plethora, facial congestion, and the cyanosis will be visible over the face. It usually happens if the goiter is retrosternal and it compresses the the venous flow, which is returning from head and neck towards the heart.
Yes.
Nishant, hello.
Sir,
Hello.
Hello.
Am I audible?
Am I
Yeah.
audible?
Am I
Nishant.
audible?
Yes.
I am Dr.
Yes, Ramisha, you are audible.
Ni-
Good morning.
Nishant. Hello, Dr. Nishant.
yes, sir. Yes, sir.
I am Dr. Bhattacharya.
Yes, sir.
Thyrotoxicosis is a clinical diagnosis. So, how will you exhibit the fine tremor of thyrotoxicosis? The hands you have shown the picture, but the videography is not there.
Yes, sir.
How will you examine the fine? How can we exhibit the fine tremor of thyrotoxicosis?
Sir, we usually place some plain A4 size paper over the hands, these outstretched hands, and then we look for these fine tremors.
Yeah, it is not there. That's why I asked.
Yeah,
Okay,
yes, sir.
thank
We
you.
have. Yeah, thank you so
Okay.
much,
In
sir.
tongue also.
Why all these symptoms occur in thyrotoxicosis? Is it due to
Basically,
thyroid hormone itself? This tremor,
no,
this protrusion of eyeball, I mean this prominence of eyeball, this increased bowel habit, and this increased sweating, palpitations, all this can happen in your exam day also. So what is the difference?
ma'am, because in thyrotoxicosis, it's because there is an excess of the thyroid hormones. Due to all these thyroid hormones, these symptoms they appear, and the mechanism for this, the ophthalmopathy or the eye symptoms is different. Where these thyroid hormones they act on the fibroblasts which are present in your orbital tissues,
That is different
which are
issue. I am telling there's so many symptoms you have described, na?
yes, ma'am.
That is this palpitation, sweating, this prominence of eyeball, this hyperhidrosis. Why these things happen with thyrotoxicosis?
Ma'am,
How does
because
the
of
thyroid hormone produce that? These things can
ma'am,
be in any stress. So
uh, true, ma'am. That this excess of thyroid hormones basically action is similar to like your sympathetic system.
yes.
So they act
So
on
we
the
are not dealing with
receptors.
adrenal gland. We are dealing with thyroid gland. So why these symptoms? These are basically adrenergic symptoms, isn't it?
Yeah,
Why adrenergic symptoms are there when there is thyrotoxicosis?
thyroid itself acts on these receptors, ma'am.
Yes. So thyroid hormone basically upregulates the beta 2 adrenergic receptors. That's why there is palpitation. That's why there is prominence of eyeball, I mean lid retraction. There is tremor. There is these things, hyperhidrosis and tachycardia. All those things are due to the upregulation of beta 2 adrenoceptors by the thyroid hormone. That is the things.
Yes, ma'am.
You have told this tachycardia with high volume collapsing pulse. So, what are the other causes of high volume collapsing pulse?
Ma'am, this high volume collapsing pulse, it is seen in
Very young.
yeah, they are seen in the ma'am high cardiac output states in the the patient the physiological it can be seen in the exercise pregnancy. They are also seen in the when the patient is having a anemia, fever, plus the vitamin deficiency, vitamin B1, wet beriberi. Some cardiac disorders they can be seen in the cardiac disorders. We have the aortic regurgitation, patent ductus arteriosus, stenotic lesions, these type of, and also in the elderly patient when there is an increased atherosclerotic vessels, which also results in there is a uh, high volume collapsing pulse due to wide pulse pressure.
Okay, so there are so many causes. They may be non-cardiac, maybe cardiac also. Very good.
Yes.
So, what are the other name of this high volume collapsing pulse?
Water hammer pulse.
Any other? Starting with C. Anyone?
Corrigan's pulse. Corrigan's pulse.
Very good. So I think, can you move your slide a little
Yes,
bit?
ma'am.
So this is your neck examination. I think other examiners have already asked question regarding this. You have you don't have any bruit, na? The patient doesn't have any bruit.
Yeah, ma'am. Sir has asked regarding why brew is important.
Okay. So what are the eye signs? Has this been discussed?
No, ma'am. Abhi, just now the things have not been discussed from the beginning. Just you started,
Okay.
only two questions were
Oh,
asked
I
by
think
sir.
then you can proceed. Okay.
Yeah, ma'am. The
Have you
patient,
described
ma'am.
this? No.
Yeah, I have described, ma'am. The patient
Your
had this
patient has
white.
lead lag, loss of wrinkling, failure to converge the eyes, and infrequent blinking. Okay, fine.
Yeah.
So what are the
So, ma'am.
names of these? Although these are not used nowadays much, but examiners will ask you. What is the other
So,
name of scientist's name?
for the lid lag, we say the failure of the upper lid to follow the eye when the finger is moved to the downward motion. This
Yes.
is the von Graffius sign. Loss of wrinkling is the Joffre's sign when the patient is asked by fixing her head to look upward in the uh, upward, the patient there will be a loss of wrinkling in the forehead. This is Joffre's sign. The failure to converse, that is when the patient is asked to look far and then we ask the patient to accommodate. There will be the failure of convergence. This is the Mobius sign, and the one more sign, that is the infrequent blinking. That the patient will have a stare look because of decreased blinking. This is the Stahl-Burgess sign.
Okay. What is Dalrymple's sign?
Ma'am, Dalrymple's sign, ma'am, when due to this thyrotoxicosis symptoms, the upper and the lower sclera is visible. That is the Dalrymple's sign.
Okay, so this patient has lid retraction. So
Yes,
probably
ma'am.
in this patient, Dalrymple sign is also present because I can see the prominent eyes and the lid is retracted out upwards. So these
Yes, ma'am.
signs are actually has historical importance. We use other things. Why from the seeing the eye, can you say whether it is Graves' orbitopathy or it is just due to thyrotoxicosis? How can you differentiate?
Ma'am, we can check for the ma'am in
How will you
the
differentiate hyperthyroidism from thyrotoxicosis? Are they the same?
no, ma'am. Actually, there is a difference. Thyrotoxicosis is basically the excess of the thyroid hormones, a state where there is the excess of the thyroid hormones. Whereas the hyperthyroidism, it means that there is the hyperfunctioning of the thyroid gland. In thyrotoxicosis, the thyroid gland may have a normal function also.
Okay, so give me some example of thyrotoxicosis without hyperthyroidism. Then I will come to the
Um,
point.
Yes, ma'am. The patient may have the subacute thyroiditis, silent thyroiditis. There may be the destruction of the thyroid gland from the drugs like that I have discussed, amidron, radiations that has been through which the patient has been exposed, uh, or there can be the excess
Subacute
intake of the.
thyroiditis and silent thyroiditis or postpartum thyroiditis, whatever it may be, here the thyroid hormone is coming out from the thyroid itself. So why it
No,
is
ma'am.
not hyperthyroidism?
Ma'am, because the gland is not hyperfunctioning.
Yes. So the thyroid hormone synthesis is not increased here. Only the
Yes,
destructive thyroiditis, so the synthesized hormone is actually coming out of the thyroid. So that is the issue. Even if, although the thyroid hormone is coming out from thyroid gland, we are not calling it hyperthyroidism. Rather, it is thyrotoxicosis without hyperthyroidism. On the contrary, even the patient is having tumor ovary. The source is ovary, but the here there is increased synthesis from ectopic sites like ovary, or in fact, I mean this follicular CA with distant metastasis. Here also, sometimes the synthesized hormone is synthesized from that place. So although it is not directly coming from the thyroid, but it is hyperthyroidism. So these things should be very clear. Although the source is thyroid, if there is no increased synthesis, we will not call it hyperthyroidism. Rather, it is thyrotoxicosis without hyperthyroidism. So regarding the eye, how can you differentiate whether it is just due to sympathetic overactivity or this is due to the Graves' disease, Graves' ophthalmopathy?
ma'am, in sympathetic overactivity, it will be more of a upper lid retraction will be there, but in the Graves, the lower lids will be involved more.
Okay, only the lids, nothing else.
Mm,
Okay, then this brings another question. What are the signs, what are the classification of thyroid associated or ophthalmopathy? I think you know it very well because it is written in
Yes,
high.
ma'am. Patient will have a congestion of eyes. Chemosis will be there. There will be redness, swelling of the upper and the lower eyelids. there will be the protrusion of the eyes. Patient may complain of later on the difficulty in visions like diplopia, and ultimately, if further it progress, the patient may have a
So what is
loss
the
of vision.
classification? There is a typical mnemonic, no?
No, that mnemonic is, ma'am, no specs.
No specs. So what are
That
they?
we
There are 7 classes.
Yes, ma'am. The first is there is no sign and symptoms. Then
Yes.
there is only the signs are present like lid retraction, lid lag. Then there is a S stands for, ma'am, there is involvement of the soft tissue, that is the periorbital edema is there, and P stands for the, ma'am, there is a proptosis that is measured with the exophthalmometer more than 22 mm, and then
If it is less than 22 mm, where it will go?
we will not consider it in
Then it will be only sign, no symptom. If it is
only
less,
sign and soft. Sir.
yeah.
Yes, ma'am.
And if it is more than 22, then it is class 3 tau.
Yeah.
Okay. And
Then,
others?
ma'am, others, ma'am, there is the effect extraocular movements of the eyeballs, they are affected, and followed by, ma'am, then there will be the corneal involvement, that is corneal ulceration, and the last will be the loss of sight and vision.
If due to corneal ulceration, there is loss of sight, where will it go?
Last.
Is it in the C or is it in the S?
Ma'am, it will be in the C. Sight vision means there is involvement of the optic nerve.
Optic nerve, very good. So sight loss due to optic neuropathy. Clinically, the patient may have Marcus Gunn people in those cases. Okay. So what is clinical activity score? This is the most important scoring system which is used nowadays to treat Graves of ophthalmopathy. Because whatever we know, we have some clinical implication.
Ma'am, yes, ma'am. On the clinical activity scores, ma'am, we have 3 subclasses. First, we give 1 point to each. If there is 3 and more, then we have to treat the disease. The first one is the spontaneous retroorbital pain. Second point is for when the patient is having a pain, having a upward or a downward gaze. Third is the redness of the conjunctiva, or fourth is the redness of the eyelids. Fifth, there will be the swelling of the eyelids, swelling of the conjunctiva, and the swelling of the caruncle.
So there are 7 points, clinical
Yes,
points. There are a few more.
Yes.
Those are not considered that much. And this is very important to take the decision whether we will give pharmacotherapy to a patient of Graves or ophthalmopathy. Because when will you want to give pharmacotherapy to these patients? What will be the score?
3 and more.
3 and more. So 0 to 2, we usually don't go for pharmacotherapy. Okay. So this is your diagnosis: Graves' disease with Graves' ophthalmopathy.
Further,
these are the investigations. Okay. So what are the classical triad of Graves' disease?
Ma'am, classic triad of Graves' disease is the diffuse goiter, Graves' ophthalmopathy, and dermopathy.
Okay. So what is that? Why does it occur? What is Graves' dermopathy? How is it manifested?
Dermopathy, ma'am, Graves. Yes, ma'am.
Have you got this in your patient? Dermopathy.
No, ma'am. The pretibial mixed edema, ma'am, it is manifested by the appearance of a pretibial mixed edema. That is the, ma'am, thick indurated raised plaque-like lesion which is present over the tibial region, and which have a surface like purely orange and orange skin like that.
Okay, so tell me the incidence of Graves' ophthalmopathy, Graves' dermopathy, and Graves' thyroid acropathy.
Ma'am, Graves' dermopathy, Graves' ophthalmopathy is present in the 33 1/3 of the patients. Dermopathy
now it has
is less
diminished. In our student time, we used to, I think others will also support me. At that time, it was almost 90%. But nowadays, it is diagnosed earlier because of more and more thyroid tests in our labs. So it has come down to less than 50%. And what is the incidence of this?
Dermopathy, ma'am, less than 5%, and acropathy, ma'am, less than 1% incident has been seen.
So what is thyroid acropathy? How will you differentiate it from a simple clubbing? Because thyrotoxicosis may have also clubbing, only clubbing.
Yes, ma'am.
So how will you differentiate?
Ma'am, there will be clubbing associated with the swollen of the swelling of the fingers with separation of the distal nail bed is also seen in acropathy.
Anything else? Why there is
Sorry, ma'am.
why there is the term acropathy? Apart from clubbing, what is there?
A
Any
nail
bone
on ankle
formation?
is destruction of nail.
That is onycholysis. But in acropathy, actually, you have a periosteal reaction. There is increased bone formation. So it is not simple clubbing. From this clue, if someone asks you, because examiners are very fond of asking questions regarding examine the face, examine the hand, examine the neck, and all three are relevant in cases of thyrotoxicosis. So if one examiner asks you, describe the hand of a typical thyrotoxicosis patient or typical Graves' disease patient, what will be your answer?
Ma'am, on inspection, the hand will have a fine tremors, pigmentation, palmar erythema will be there.
Yes.
On touching, on palpation, it will be warm, moist, hand will be
Have you
there.
shaked your hand
And
with the patient?
yes, ma'am.
Have you shaked your hand with the patient? This is
Yes, ma'am.
customary. We used to talk
Yes.
like this, that if you shake your hand with the patient, you can differentiate whether it is due to anxiety state or thyrotoxicosis. Because in anxiety neurosis, there is cold sweats, cold moist hand, and in thyrotoxicosis, we have warm moist hand.
Warm, moist hand will be there.
Yes. So these are the findings. And also you have to include your pulse.
Yes.
Pulse of the patient. Okay.
Pulse,
So
pulse.
you have
Yes.
told pigmentation. Why it is the patients are pigmented? Usually we see that the patients are very dark colored. They often complain that there is a darkening of the skin. Why is it so?
Sorry, ma'am. No.
Actually, what happens? There is, there is increased cortisol metabolism. Endogenous cortisol is metabolized more because thyrotoxicosis is a state of increased metabolism. So endogenous cortisol is metabolized. So there is a pseudo-Addisonian effect, as if there is an adrenal insufficiency. So this is the first point. And second, mostly theoretical, it is a rare occurrence, that they are not very rare, uncommon, I would say, that there may be autoimmune polyendocrine syndrome. So there may be additional Addison's disease. So these are the causes why their patients are usually hyperpigmented. So we'll not waste much time. This is your investigation, okay?
Yes,
So
ma'am.
just say what are the investigations?
So, while performing the routine investigations, the routine complete hemogram, electrolytes, and renal profile was normal. Thyroid profile demonstrated the very low level of the TSH levels. FT4 and FT3 were raised. ECG showed sinus tachycardia with regular rhythm. The echo findings that demonstrated the LV, the ejection fraction was 68%. Rest it was normal.
Okay. Why LV ejection fraction is more?
Ma'am, already, ma'am, as we have discussed this, the thyrotoxicosis is a hyperdynamic state, so which results in the more increase in this LVF output.
Okay. So now we are focusing on investigations now. So what investigation will you do to confirm the diagnosis?
Ma'am, usually, ma'am, after getting this picture, the thyroid profile, we can say it's a state of hyperthyrotoxicosis. Later on, ma'am, we can go with the the radionucleotide uptake scan that I have discussed to demonstrate the uptake in the thyroid tissue.
Why technetium 99 scan? Why not radioiodine scan? Because that is more physiological. Why not so? You have done correctly. Technetium 99 participated scan is mostly used, but why not radioiodine? That is more physiological.
But radioiodine we are giving for the treatment.
Yes, but
yes,
for iodine uptake is the thing which we will see now. So why not radioiodine? Previously it was used. Actually, it is not used now. First, there may be some hazards, health hazards. Second, it is very fast. Here,
Hmm.
there may have to wait for 24 hours, 48 hours. The clarity of image is more in technetium 99 scan. It is cheaper also and available also. So we have shifted from radioiodine scan to this technetium 99 scan. Anything else you want to do in this patient?
We can go for thyroid TSH receptor antibody assess to assess whether these antibodies are present.
In every case?
Specifically, ma'am, for the pregnant patients and to check for the response to our treatment
Pregnant
for the
patient, we cannot
prognosis.
do this radioisotope scan. So
yes, ma'am.
another thing is that we may monitor whether it is improving or not, whether we can withdraw the antithyroid drugs or not. For that purpose, TSH receptor antibody is sometimes done, many a times done, although it is costlier than technetium scan. Okay. So you have more slides?
No, ma'am.
Okay,
This
tell me
TSH
few.
receptor.
Okay, so just one or two questions, because we will move on to the next case if the others permit, our teachers permit. So what are the neurological manifestations or associations of these things?
Ma'am, the patients they have the patient, they are more insomnia like symptoms. They are irritable, they have the apathetic look. The patients usually, when we examine the patient, they have these fine tremors. They have the proximal myopathies are present in them without fasciculations. They may have difficulty in getting up from the sitting position.
Fasciculation is
And
not that common. There is
patient, they have hyperreflexia is present
Yeah.
in due to this thyrotoxic state.
Any other involuntary movements? Not fasciculation, but that is common. We do that
Fine tremors they have.
in investigation of chorea. We have to exclude thyrotoxicosis. So that is an uncommon manifestation. Okay. Any other association? Suppose the patient has come to you, you expect that the patient has a large goiter, other features are of thyrotoxicosis, but the patient has ptosis instead of staring loop. So what will you think of?
The patient may have the associated myasthenia gravis.
Myasthenia gravis. So these associations we have to remember, and also the periodic paralysis in Asian males.
The hypokalemic periodic paralysis can manifest.
Briefly describe how will you treat the patient before we move on.
Ma'am, first we will start the patient on the antithyroid drugs. That we are the thienamides group of drugs. We have this propylthiouracil, methimazole, carbimazole drug. We will treat the symptoms of the tremors with the propranolol. And for the ophthalmopathy
do you
part,
routinely use beta blockers?
No, ma'am. If the patient is symptomatic
when do you give beta blocker to a patient of thyrotoxicosis? What are the indications along with antithyroid drugs?
Patient is having tremors which are interfering day-to-day activities. Patient is having a sinus.
So in the initial phase, before the antithyroid drugs come into action. Okay, that's fine.
By the time
any other indication?
Sinus means tachycardia is there, ma'am.
Yes. So anything else?
Ma'am, if the patient has developed a complication. Yes, ma'am. If the patient is at thyrotoxicosis, then we have to give.
If the patient is in thyroid storm, then you have to give, because that reduces the peripheral conversion. Anything else before any other modality of treatment?
Before giving radioactive iodine therapy.
More so before surgery, you have to give beta block. And also in periodic paralysis, because there is intracellular shift of potassium due to sodium potassium ATPase activity. So that can be overcome by beta blocker, not only by antithyroid drugs. So these are the things. So what are the other modalities? Which do you use more? Which drug do you use more?
We use this methimazole and carbimazole group.
Okay. Why not propylthiouracil? It is a better drug now? Because it is used in thyroid storm also. So why not propylthiouracil?
Ma'am, it has this major side effects of hepatotoxicity, and it can cause agranulocytosis.
Agranulocytosis both can cause. But propylthiouracil can cause jaundice, both can cause. but propyl thyroxine can cause fulminant hepatic failure. Whereas methimazole, carbimazole, they actually cause cholestatic jaundice, which are less severe. So apart from pregnancy, we usually don't use pregnancy first trimester. We usually
First,
use propyl thyroxine unless and until there is thyroid swell. Okay. So what are the other modalities of treatment?
ma'am, we have if the patient is not responding to the drugs, then we have the radioactive labeled iodine therapy that we can give. And still, if it's not responsible, we can go for the subtotal thyroidectomy surgical procedures to remove the thyroid part of a thyroid gland.
When surgery is indicated?
When the patient is not, either the patient is having these relapses, not responding to the treatment, or there is the certain effects, ma'am, the surgical compressive effects the patient is having.
Compressive symptoms. So we have to go for surgery. There is large goiter with compressive symptoms. So I think much discussion has been done because we have other two cases. Does anyone want to ask any question to Nishant? Can you stop sharing? Stop sharing.
Ma'am.
You have stopped it? No.
Just stopping.
If there is no further questions or answers or any comments,
I have one question, madam.
there are questions in the chat box. So, Mr. You can discuss.
Yes, given one question in the chat box. Thyroid stimulating immunoglobulin.
Yes. This is the whether Nishant will tell it or I will tell it.
No, madam. Anyone. No issue.
Okay. Thyroid stimulating.
Madam, you please tell me. Tell that answer. You please answer
Role
that
of
question.
TSH receptor antibody in diagnosis of Graves, you have discussed. Any advantage of TSI antibody? Thyroid stimulating and immunoglobulin is the pathogenesis. It is in the pathogenesis of Graves orbitopathy because that is the immunoglobulin which actually stimulates the TSH receptor to produce instead of TSH. To produce more and more thyroid hormones, and TSH receptor antibody we measure. So these things are different. One is the endogenous immunoglobulin, which is responsible for the pathogenesis of the disease. And when we measure in the laboratory, we use TSH receptor antibody, which is almost similar in prediction than is this endogenous TSI. So TSH receptor antibody TRAB is basically a lab report which we use to diagnose, and TSI is the endogenous immunoglobulin which is responsible for the pathogenesis. This is the minor difference.
Yes.
Anything
Thank
else?
you.
Dose of corticosteroid in Graves ophthalmopathy. Someone has asked. I think Nishant will say it. I had some good slides, but due to lack of time, I cannot show it. Okay, we'll discuss later on.
Yeah, steroids, they are initially the steroids, they are indicated if there is a moderate to severe form of the eye disease, and the steroid therapy that is available, if there is a symptoms that is involvement of the optic nerve, then we can go for the methylprednisolone therapy.
If the clinical activity score is 3 and above, that is the
3
standard.
and above.
Okay.
Yeah.
So what is the dose of the steroid?
We go for a 500 mg IV once a weekly for 6 weeks, then followed by for another weeks 250 milligram IV. For another 6 weeks we go. Ma'am.
Okay. So we should remember that apart from this steroid, we should also advise the patient of some non-pharmacological therapy, like wearing sunglasses with sight cover and methyl cellulose drop locally. And so your answer will be whenever you will be asked about the management of Graves ophthalmopathy, there will be three parts. One is non-pharmacological, second is pharmacological. As you have already told, the steroid is the mainstay of treatment. We can also use other steroid sparing immunomodulating agents. And you must remember one recent advance, that is teprotumumab. You know what is it?
Yes.
Teprotumumab is the new modality monoclonal antibody. Basically, it targets the receptors which are present in the orbital tissues. The IGF-1 and TSH receptors that it targets.
Recent advance. Okay. And there are surgical therapies too. particularly lid surgery, strabismus surgery, and decompression surgery.
Yes.
One just practical question regarding beta blocker in Graves' disease. Which one should use? Like short acting propranolol, Inderal, or is the longer acting or sustained release like beta captia? Any sort of advantage of long acting?
I think both do work.
Yeah.
Long acting and short acting both do work. But sometimes cardioselective beta blockers are also used nowadays.
Right.
If there is cardiac manifestations more, particularly in
So
apathetic.
bisoprolol we can use also. Bisoprolol or metoprolol we can use.
Yeah.
Right.
Actually, Parthoda told me to show some slides. Can you?
Hello.
Slides?
Hello. Can I speak? Hello, Dr. Nishant.
Yes, sir.
Apart from drugs, what are the nutritional replacement therapy we should administer to a patient of thyrotoxicosis? Apart from drugs, what are the nutritional replacement therapy we should administer to a patient with thyrotoxicosis?
Nutritional.
Kaushik, can you allow me to share the screen for just 1 minute?
Yes, you must show your slides because that will be much helpful for the trainees also. Dr. Kormukar,
It
sir.
is disabled. So can I show just one slide? If Kaushik makes me
Definitely. When Dr. Chairperson Madam is wanting to show some slide, it is to be allowed. Dr. Kaushik, please have a talk with Madam.
Okay, I have already
please
shared.
arrange it.
Okay.
Okay.
So this is as per Parthoda's request. Can you see it? So Parthoda actually, Professor P.S. Kormukar told me to differentiate how radio technetium 99 scan is read. So you can see that this is a normal scan in the center. So we must have some view of the buccal salivary glands. So this is the normal uptake. This is the normal scan, and you can see here that this is the buccal glands where there is minimal uptake, but still it is there. In Graves' disease, there is increased uptake, but it is diffuse, and there is no salivary gland uptake. In toxic adenoma, there is localized increased uptake, and the other surrounding tissues, there is no uptake because toxic adenoma is an autonomous secretion of thyroid hormones. So it suppresses the TSH, and the uptake of iodine or whatever it may be, what is the radioisotope, that depends on increased TSH. So in those cases, the surrounding tissue, it doesn't have any uptake. Similarly, in toxic multinodular goiter, you can see that, there are certain discrete areas of increased uptake intervened by decreased uptake. And on the right top, it is subacute thyroiditis, where there is heterogeneous uptake, usually it is decreased uptake due to destructive thyroiditis. So this sort of picture, that is the right upper corner, that is the picture which we get in subacute thyroiditis, silent thyroiditis, and postpartum thyroiditis. So these are the pictures
extremely good picture.
Just from one slide, you can understand how you can diagnose any sort of thyrotoxicosis with technetium 99 scan. And just 30 seconds, this patient actually came to me just yesterday. So I thought that I would take a picture of the patient, because you can see that this patient has 3 clinical activity score on the basis of which we should start treatment. So this is the conjunctival congestion. What Nishant has mentioned, there is periorbital swelling, and there is also pain during movement. So among the 7 clinical activity scores, 3 is there. So I actually will start the patient the methylprednisolone. Patient has already come with a CT orbit report to me, because there is some other endocrinologist has advised it. And you can see here that this is the optic nerve. And this is our dictum, is that if the belly of the inferior rectus or medial rectus or extraocular muscles, they are wider or they are fatter than the optic nerve, then definitely there is glycosaminoglycan deposition in the optic this extraocular muscles. So you can see here, optic nerve is slender, but these muscles are so plump. So definitely the patient is having this Graves or ophthalmopathy. Actually, for this patient we don't have. So I thought that if I give this, if I show this, then definitely it will add some points to the discussion. Thank you. So should we move to the next case, which I think will be very short discussion?
Yes,
Yeah.
definitely. You please
Sure.
proceed.
So Shubham, if you please give your slides.
Yes, ma'am.
So you give the short history and short examination, because the examination part is already covered. So it will be more direct questions. Yes.
Uh, Welcome all the seniors and my teacher, Dr. Somishram Kuwadhyay. So today my case-based discussion for the short case is solitary thyroid nodule. I start with the chief complaints. This 38-year-old female homemaker residing in Kolkata complained of swelling in the front of the neck for 6 months. Then history of present illness. Patient noticed a painless swelling in the lower part of the front of her neck 6 months ago. The swelling has gradually increased in size, not associated with pain, redness, or discharge. No history of hoarseness of voice, difficulty in swallowing, or breathing difficulty. No complaints of weight loss, heat intolerance, palpitations, or increased appetite. No history of weight gain, fatigue, constipation, or cold intolerance. No history of any other swelling in the neck. No history of loss of appetite, bone pain, headache, fever, dyspnea, or jaundice. Then history of past illness, no history of childhood head or neck therapeutic radiation, no past history of thyroid disorder, no history of known any chronic disease, no history of any established tuberculosis. Family history, when it's not contributory in this case, no family history of any thyroid cancer or thyroid disorder. Personal history is no history of any addiction, normal appetite, normal bowel habits, and normal sleep pattern. Menstrual history is para 2 and 2 with two living children. Menarche 13 years, LMP 12 days back, and regular menstruation. Physical examination, I start with the general examination. Mild, middle age, moderately built female, vital stable, BP
Is anything
and pulse.
which can contribute to your diagnosis, or everything is normal? If it is normal,
So,
then
ma'am,
skip it because of lack of
okay,
time.
ma'am. Okay, ma'am. The general examination is quite normal. Then on the local examination part, a solitary firm non-tender nodule felt in the right lobe of thyroid, approximately 2.5 into 2 centimeter, moves upwards with deglutition, not moving with protrusion of the tongue, margins well defined, lower limit palpable, rest of the thyroid non-palpable, trachea is central, bilateral carotid pulse is palpable, no bruit or thrill heard, no other swelling in the neck.
Okay, so I'm skipping the examination part. You have done it, I think. So how will you approach to
This
this
means
patient?
that,
You have a solitary thyroid nodule. Is it your diagnosis?
yes, ma'am.
Okay, so,
Ma'am,
so how?
my provisional diagnosis after
Okay, you give me the summary. You give me the summary.
yes, ma'am. So summary of this case is 38 years old female solitary thyroid nodule in the right lobe of thyroid, clinically ethiodyte in sinus rhythm without any compressive symptoms.
Okay, so how will you approach to this patient? How will you investigate? We'll just discuss
After taking,
in this patient.
okay, after taking thorough clinical history and physical examination, I first do the blood test, that is thyroid function test, TSH, FT4, and FT3. And for in this case, everything blood parameters are normal. So
So what will
then
you do? patient has got, say, low TSH and high FT3 and FT4, just like the previous case?
If the TSH is suppressed, ma'am, then I will directly go for radionuclide scan and
Yes.
check for if any hot nodule is present in the radionuclide scan.
So
If
that is a very
TSH
small
is
fraction.
not, yes, ma'am.
Most of the cases, you will get either normal thyroid function or it may be hypothyroid. TSH is like
Yes.
the high with lower normal FT3, FT4. So what will be your approach to those patients who are non-thyrotoxic? That is the major share of the patient.
Yes, ma'am. So if the TSH level is normal, then we have to go for the high resolution USG of the thyroid gland, like in this case. And if on the based on the USG features, we have a scoring system, risk stratification scoring, that is ACR TIRADS. If that USG features is indicative of the FNSC.
So actually, I'm just that in 1980s or early 90s, in most of the patients of thyroid nodule, the endocrinologists or physicians, they used to do technetium-99 thyroid scan or radioiodine scan. But that actually, what was the problem? In 99% cases, 95% cases, they were cold nodule. And among those 95%, only 5% were malignant. That's why it has become obsolete, and we are reserving technetium-99 scan to those subset of patients who are thyrotoxic. But for the major share of patients, our diagnosis is USG based because that gives us more chances to delineate the structure, what is there actually, and more to find out the malignancy, and it also inhibits us, it also helps us to prevent unnecessary FNSC. So that is my comment. Now you can proceed. So what is your finding in this ultrasound?
This is a TIRADS 2 nodule, mainly cystic. In the transthyroidal view of dimension.
Question: what is TIRADS? What is
TIRADS? TIRADS is the thyroid imaging and reporting data system. It has 5 components.
This is from American College of Radiology, ACR TIRADS.
Yes, ACR TIRADS. It has 5 components: composition, echogenicity, shape, margin, and echogenic foci.
So what are they? What are the TIRADS 1, 2, 3, 4, 5? Can you tell me?
Yes, TIRADS 1 is 0 points. There is no indication of FNSC. TIRADS 2 is mainly benign, and there is also no indication of FNSC. TIRADS 3 is mildly suspicious, and TIRADS 4 to 6 is moderately suspicious, and TIRADS 5 is highly suspicious. Points is more than 7. And for TIRADS 4, if this is moderately suspicious, indication for FNSC is if the size is more than 1.5 centimeter. And for TIRADS 5, if the size is more than 1 centimeter, we have to do the FNSC.
So from TIRADS 3, we'll think of FNSC. For TIRADS 3, it is more than 2.5 centimeter. For TIRADS 4, it is more than 1.5 centimeter. And for TIRADS 5, it is 1 centimeter. So this is the data. So what is our duty as a physician? So we have to advise the radiologist that please do TIRADS scoring. Sometimes the patients come to us without having the TIRADS score. Just written it is cystic or it is solid or something like that. So we cannot take the decision because we have definite algorithm. So whenever you prescribe ultrasound of neck to a patient of suspected solitary thyroid nodule, your advice to the radiologist will be that please give TIRADS score. Okay. So good. So you have TIRADS 2 nodule, benign. So
yes.
Suppose there is a TIRADS 4 nodule and you have done your FNSC. So how will you classify the FNSC findings? That is also important. That may come in your short note too.
Ma'am, we have a risk stratification scoring based on the cytology that is we got from the FNSC. It is called Bethesda classification. It has
what is Bethesda? TIRADS you have told, thyroid imaging reporting and data system. So what is Bethesda?
Yes, ma'am. Bethesda is the risk stratification scoring based on cytology.
But why is the term Bethesda? Tyrus, you have explained now full form. So what is Bethesda?
Yes,
Why is it Bethesda scoring? That I am asking. Bethesda classification. From where the name comes? Even if you don't give the answer, heaven will not fall. Just for some interesting thing. Bethesda is the name of a place. It is near Maryland, USA, and the first when this recommendation was accepted in a cancer institute in Bethesda. That's all. Okay, so this is the name of a place. So now tell me, what are the Bethesda classification of histopathology, FNS?
It has got 6 diagnostic category. First one is non-diagnostic or no unsatisfactory. Second one is benign. Third one is a follicular lesion of unknown significance, and fourth one is follicular neoplasm.
Atypia of unknown significance and follicular neoplasm of unknown significance. AUS
unknown
or
significance. And fourth one is follicular neoplasm. Fifth one is probably malignant, and sixth one is malignant. There is a percentage of risk of malignancy for the first class. It is 5 to 10%. For the second class, that is benign, it is 0 to 3%. For the third class, that is with some atypia or a follicular lesion of unknown significance, it is 10 to 40%.
Third class 3. Yeah.
Yes, ma'am. And the fourth class with follicular adenoma, it is 25 to 40%. And with the fifth and sixth class, it is respectively 50 to 75%. And in the malignant, it is more 97 to 99%.
Okay. So how will you treat this patient? This patient with TRAS2 nodule with a cystic nodule. How will you treat this patient?
For this case, ma'am, it is a benign nodule. There is a.
I am asking how will your treatment differ from Bethesda 1 to Bethesda 6? So this is TRAS2 nodule. How will you treat this patient? Say this is Bethesda 2.
For this TRAS2 nodule, ma'am, we have to no indication of FNSC, or we can have different treatment modalities like levothyroxine suppressive dose. We can give the levothyroxine to the patient, and that will suppress the TSH, and
that may suppress the growth of the nodule, but in cystic nodule that usually don't work because this is only fluid filled cavity. So TSH overdose of supraphysiological dose of L-thyroxine does not work in these cases. If it is solid or solid cystic nodule, then it may work. And for these nodule, what is the ideal treatment? Which is not written in Harrison, but it is done in practice.
We can go for percutaneous ethanol injection.
Yes.
And also the laser thermal ablation LTA.
These are the alternate. Percutaneous ethanol injection, USG based, is used. Many endocrinologists do it, and we have also done it in IPGMR when we are DM students. Nowadays, it is less used, but still it is used because unless and until there is very large cystic nodule, we don't advise the patient to go for surgery if it doesn't cause any cosmetic symptom. Okay, if the patient has got say malignancy, Bethesda 5, say malignancy, then how will you treat the patient?
We can go for surgery like near total thyroidectomy, and after surgery we can actually, after surgery we have to do for monitoring of the patient post operative. We can go for whole body radioiodine scan, and if there is residual disease
before doing whole body radioiodine scan, what instruction will you give the patient? Because you have done near total thyroidectomy, fine, there is no complication.
Yes.
What complication may happen? At least say 2 complications. What can occur after near total thyroidectomy? Because no one will call you during the surgery, but they will definitely call you after the surgery when the things are at mess. So what are the problems?
After surgery, ma'am, there is a possibility that there is the total clearance is not happened. Like there is a presence of residual disease and post-operative complications like hoarseness of voice for the.
This is near total thyroidectomy, so residual thyroid may be present. But what are the two notorious complications? One is definitely recurrent
One
laryngeal
is
palsy,
recurrent
which is not
laryngeal
our
palsy.
job. This is ENT surgeon and surgeon's job. But the people often call physicians for hypocalcemia, because there is inadvertent removal of the parathyroid glands. So it is very
Yes, ma'am.
difficult to identify during the surgery. Sometimes lymph nodes and parathyroid glands, they are almost similar in blue. So after, in the post-operative period, we get call from surgeons because there is hypocalcemia, which may be transient or maybe permanent. So that is from physician's point of view, because surgery is not our cup of tea. Okay. So suppose there is no complication of the patient and you are advising the patient a radioiodine scan, whole body radioiodine scan, to see whether there is any residual disease or not. So before that, what will you advise to the patient? After near total thyroidectomy, what are you giving to the patient?
After neonatal thyroidectomy, ma'am, I would suggest levothyroxine.
Yes, you have to give high dose levothyroxine because the thyroid is already gone.
Yes.
So you have to give
Yes.
levothyroxine replacement therapy. So before advising a patient for whole body radioiodine scan, these are the practical points. What will you advise to the patient?
At least 1 to 2 weeks prior to stop the levothyroxine.
Not
and
1
to
to 2
maximize
weeks.
the uptake.
Levothyroxine has a long half-life. So you have to stop it 4 weeks, at least 4 weeks back. But if you give liothyronine instead, then you can stop it before 1 to 2 weeks. Okay. And what are the alternatives now available? We are not using, but many centers are using.
To maximize the uptake, ma'am, we can use recombinant TSH injection.
This is
0.9 milligram.
But I am just hammering this thing, emphasizing the things, because if we stop levothyroxine, say 4 weeks before doing radioiodine scan, the patient's quality of life will be in very bad, because he will have high TSH. We are rising TSH because unless there is raised TSH, there will be no radioiodine uptake. TSH, radioiodine uptake is dependent on high TSH. So we are rising TSH level, but the quality of the patient's life will be very bad because he has no internal source of thyroid hormone. For those things nowadays, not nowadays, it has there from I think 1.5 decades at least, that we don't stop the levothyroxine, but we are giving recombinant TSH instead on the on addition to that. So that will raise the TSH level and that will allow the patient to have uptake, iodine uptake. So that is a good thing. So how will you monitor this patient? Suppose iodine uptake, whole body radioiodine uptake has been done. There is nothing. So it was a localized disease. So how will you monitor this patient? The patient will come to you.
First, yes, ma'am. First, initially, 1 to 6 months. Every 6 months, we have to do USG and with that serum thyroglobulin. If the serum thyroglobulin is more than 2 nanogram per ml, then we have to suspect there is a chance of metastasis. Then
Why
we have
not
to go for
TSH? Why thyroglobulin?
thyroglobulin, ma'am. TSH patient is already on the levothyroxine therapy, so TSH will be suppressed.
Right. So how can you assay with TSH? That's why we are taking help of thyroglobulin,
yes,
which is intrinsic to the thyroid. Okay.
Intrinsic to the.
There is one additional point which is often not written in medicine book, that apart from thyroglobulin, we also do anti-thyroglobulin antibody. Because if there is significant amount of anti-thyroglobulin antibody, that may increase or decrease, that may jeopardize the level of thyroglobulin. So if you do an additional thyroglobulin antibody, and if it is negative, then your assay reliability will be more for thyroglobulin. So at least 6 monthly thyroglobulin and USG for local recurrence of the disease is mandatory for these patients. And what will be your TSH target? Because you are giving levothyroxine. Suppose the patient is suffering from a papillary CA thyroid, which is
how long the patient should be monitored for this type of recurrence?
That is
6
a very
monthly.
important question.
That is one question. Another, just you have already what you have discussed, that most of the hypocalcemia following thyroidectomy for this type of problem is temporary, but
Yes.
the clinician must also know what percentage of patients actually have permanent hypocalcemia and require lifelong replacement. But because that is one of the most important area which we actually face some challenges. So
Yes. So may I answer?
yes, sir. Yes, ma'am.
Shubham,
Sure.
because I think that is a little bit endocrinologist point of view. He is only first
Yes.
year PGT.
We have to, but
So better
as a clinician, we have
understanding,
to treat this type of
I am
problems.
just
Yes.
adding
Yes.
2 points that this temporary hypocalcemia is mainly due to jeopardization of the vascularity during OT. So it will gradually subside. But if the patient has hypocalcemia, we have to give IV calcium gluconate, but mainly through infusion pump. This is one point. Second thing is that if there is permanent hypoglycemia, we are monitoring the patient, and even after oral replacement therapy or by calcium, the calcium level is not increasing. In that case, we'll think that definitely there is some injury or some removal, unknowingly or unintentionally, there is removal of parathyroid gland. So how to manage these patients? First of all, we should remember that these patients should be managed just like hypoparathyroidism. So only mere giving of calcium to these patients will not improve the calcium level of the patient, because these patients need, in hypoparathyroidism, what we need additional alpha D3, because this is the thing, because parathormone helps conversion of this 25 hydroxy to 125 hydroxy vitamin D3. That conversion is helped by parathormone. So unless and until we give this alpha D3 to this patient,
Vitamin D3 along with calcium. So we have to replace.
Exactly. So that should be remembered by the
So
students, because that is a
another
common
important.
mistake, that sometimes only calcium dose is being increased and the patient is not getting the result.
Yes.
Okay, so
And the
Shubham,
second part, that how long we need to actually, we have to monitor 6 monthly thyroglobulin ultrasound. So what is the recommendation? Just
Shubham, will you answer it?
Ma'am, initially 6 monthly USG and serum TG for next 5 years, then annually.
yes.
And
For
that
how long?
too, it also depends on the extent of the disease. This is very important, because our TSH target is also dependent on extent of the disease. If it is local, then after years we may discontinue, because the chance of recurrence is less than 3%. Okay, and our TSH target is also less. If we have distant metastasis, then our TSH target is less than 0.1, because we want to suppress the TSH so that there is no local growth. When there is intrathyroidal extension along with the lymph nodes or like that, then our initial target of TSH is 0.1 to 0.5. And later on, after a few years, we may keep it at normal range. And when it is very localized, even from the beginning, although there is certain risk that we may have to keep it 0.5 to 2. So this is the dictum. So in most of the cases, if there is no distant metastasis, we usually keep it from 0.1 to 0.5 TSH level. Previously, we were more stringent. We used to keep all patients below 0.1 after thyroid surgery for differentiated carcinoma. But nowadays, because the patient's quality of life becomes very bad, there is bone loss, there is also chances of cardiac arrhythmias, because we are giving supraphysiological dose. So in those cases, we are now less stringent because of the localized disease and less metastasis. So we are keeping the TSH level between 0.1 to 0.5. And for distant metastasis, okay, we have to keep TSH below 0.1. So is there any question in the chat box? Because
Thank you, sir.
Our case is very interesting. So should we move to our third case by Dr. Abhishek Singh?
Yeah, please move, because we are running short of time.
Yeah.
Please,
that's why. So I think Abhishek, stop sharing. I had some slides, but I'm skipping it. It's better Abhishek should come.
Should we start? Should I start?
Yeah.
Yeah.
This case is very interesting. I think this case itself is self-explanatory.
Okay. So, very good afternoon, everyone. All my respected teachers and my colleagues. Today, I'm going to discuss an important endocrine case with you. It's a case-based discussion on acromegaly. Just a minute, my screen is not loading.
Share screen?
Yes. Ma'am, is it visible?
No.
It's not visible?
You share the screen and add you have minimized your presentation, no?
Okay.
Yeah, it's coming.
Okay.
Okay. So be a little fast.
Just a minute. Some glitch. Okay, I can start like this. So my
Start
case,
from the chief
basically,
complaint.
I'm starting with the chief complaint. My case is a 51-year-old female homemaker who presented to us with features of coarsening of facial features and broadening of hands and feet size over the past 17 years. She also complained of excessive daytime sleepiness and snoring since similar duration. Another complaint was excessive sweating, appearance of facial hair since the past 16 years, and gradual decrease in the peripheral vision in both of her eyes over the past 15 years. Now, coming on to the history of presenting illness, my patient was apparently well 17 years back when she first observed gradual broadening of her hands and feet, as evidenced by a progressive increase in her ring and shoe sizes. There was gradual coarsening of the facial features, including the prominence of the jaw and the forehead, which was mentioned by her family members as well. Now, there was excessive daytime sleepiness and loud snoring for the past 17 years, as reported and corroborated by her partner as well as her family members. There was increased sweating and development of facial hair, particularly over the upper lip and the chin, which started approximately 16 years ago. And there was a gradual difficulty in noticing objects located towards the periphery of her visual field over the past 15 years. Now, history of presenting illness continued. Now, this is the important negative history in this case. There was no history of headache or seizures, drooping of eyelids, double vision, facial numbness, abnormal smell sensation, galactorrhea, irregular menstrual cycles, postural dizziness, hypoglycemia, cold intolerance, constipation, no history of renal calculi or pathological fracture, and there was no history of polyuria or polydipsia as well.
Can you explain why have you taken this negative history?
Okay.
I can understand that headache. Definitely, if there is a pituitary tumor, there will be headache. Why seizures?
And seizures, if it is an advanced cases, there can be a cortical involvement as well, cortical compression. So that is why seizure has been taken.
Maybe
Though
hypothalamus,
hypothalamus compressions can be there.
So there may be gelastic seizure.
Laughing seizures, yes.
Yeah, and this point, drooping of eyelids, double vision, facial numbness. What are you excluding by this?
Ma'am, I'm excluding the that is the invasion in the cavernous sinus. That is all the cranial nerves involved. By the drooping of eyelid, the third nerve, and the double vision, also the 3, 4, and 6 cranial nerves are involved. That is a lateral invasion of the
facial numbness for?
Facial numbness for the trigeminal involvement. That is the V1
first
and V2.
Division of ophthalmic. Okay. And why are you asking for galactorrhea in this patient?
In galactorrhea, first, it could be due to hyperprolactinoma because of the co-secretion from the tumor itself, or it could be a secondary due to a stalk effect because of the tumor. That is, there could be an hyperprolactinoma.
Very good. So there may be compressive hypogonadism, there may be prolactin level may be high due to co-secretion, and there may be also stalk compression. And just one point, why you are taking the history of renal calculi and pathological fracture?
Ma'am, renal calculi, because pituitary adenoma could be a feature of the men syndrome as well. And in the men, there
Yes.
is another like hyperparathyroidism could be men one that is hyperparathyroidism because of the parathyroid adenoma could be present. So that is why I've taken the history
Whenever
of
there
renal
is a pituitary tumor, we will always think of and will search the history of main one components. Okay. Okay. Polyuria, polydipsia, I can understand. You have taken the history of involvement of posterior pituitary.
pituitary.
So you please continue.
May I interfere just for a minute?
Yes, yes.
Just do you think that you should also take history of any muscle weakness?
Yes, sir.
Proximal
Muscle. Yes,
myopathy?
yes,
Why?
yes, yes, sir. It should be taken
Why?
because in that is like my case. What is acromegaly? There is always
Yeah.
there is a component of proximal myopathy in this
Right.
patient. So muscle weakness, there can be features of the like difficulty in combing or overhead or getting up from chair. So proximal myopathy weakness could be present.
Do you
So
think
what are
that?
the endocrine diseases that can cause proximal myopathy?
Yes. Yes.
Like it could be
there are many endocrine and metabolic diseases that can cause proximal myopathy. What are they? Endocrine and metabolic diseases.
Hypothyroidism could be one of the
Yes.
causes of this. Even diabetes, if it is uncontrolled diabetes, can be one of the causes of this. And
Mhm.
even for the metabolic other causes, it could be
No, endocrinal cause. One very important endocrinal cause you was missing. That is pituitary lesion causing, say, Cushing's. And that
Cushing's,
can also
okay.
produce proximal. Recently, I got
Proximal.
one patient who is actually presented to us with typical features of Cushing along with proximal myopathy. And diabetes, usually it is diabetic amyotrophy. Proximal, again, proximal muscle weakness. Yes.
So, should I proceed? Hello.
Thank you. Continue, please.
Yes, sir. Okay. Thank you, sir. So the continuation with the history of presenting illness. In January 2010, she was diagnosed with acromegaly due to pituitary macroadenoma, which was confirmed biochemically and radiologically. She underwent transsphenoidal pituitary surgery, followed by an adjuvant radiotherapy in the same year. Following her treatment, her symptoms became clinically static with no significant progression for the next 6 to 7 years. However, from early 2019, she began experiencing the recurrences of the similar previous symptoms, including increase in the sweating, snoring, and the soft tissue thickening. So she came to our clinic in April 2025 for re-evaluation. Now, moving ahead with the treatment history, what she has received so far. So, she was diagnosed with acromegaly in 2010 and underwent transnasal transsphenoidal endoscopic excision of the cellular lesion. Post surgery, she received tablet prednisolone 5 milligram once daily, the duration of which is not recalled by the patient. She was also given tablet desmopressin 0.1 milligram for 2 days. Post surgery, she also received this adjuvant radiotherapy, and post radiotherapy, she was put on tablet bromocriptine for 1 year. Can I proceed?
Yes, please.
Okay. So now coming to the past history, there was not significant. There was no history of any past illness or past surgical that is history. Personal history, the noteworthy finding was because of this that there was excessive daytime sleepiness was present. Rest of the personal history was within that is not corroborative. In the menstrual and the obstetric history, there was no history of menstrual irregularities. And as far as this obstetric history was concerned, that was gravida 2, para 1, with one induced, that is in cases of the abortion was there, and with one living issue. And the family history was also not significant. Can I proceed to the summary?
Sure.
Okay. So now summarizing my case so far, my case is a 51-year-old female who presented with a 17-year history of progressive coarsening of facial features, enlargement of hands and feet, excessive sweating, facial hair appearance, and loud snoring with daytime somnolence. She was diagnosed with acromegaly due to a pituitary macroadenoma in 2010 and underwent transsphenoidal surgery followed by radiotherapy. Now, symptoms remained static for 6 to 7 years post treatment. However, since 2019, she has experienced recurrences of the symptoms, including soft tissue overgrowth and snoring, along with persistent progressive decrease in peripheral vision in both of her eyes over the last 15 years. There are no symptoms suggestive of other pituitary hormone excess or deficiency. Okay. Now, moving ahead with the clinical examination. So this is the photograph I've taken with the consent of the patient herself. So this is when she presented to our clinic. This is the initial photograph. And as you can see, The facial features of that is in case of characteristic here, there is frontal bossing. There is basically the prominence of the supraorbital ridges, as you can see in this patient. There is a broad nose with a broad lips is there. And also there is basically in the side view, we can see the prominence of the chin, that is the prognathism, which is seen in this patient. And this is basically the increased interdental spaces which we see in cases of acromegaly patients because of the increase in the size of the jaw. Now coming to the general, so this is what I've written in the general examination. In the facial appearance, there is coarsening facial features, frontal bossing, prognathism, thickened lips and nose, macroglossia, and increased interdental spaces. Moving ahead with the general examination. Now this is the two classic neck findings, or you can say not neck findings, but skin findings, which is seen in cases of the acromegaly. One is the presence of acanthosis nigricans, and the second is basically the presence of the skin tags, which is seen in cases of because of this growth hormone excess in this patient. And this is the pictures of the hands and the feet I've taken. These that is broad and wide hands and feet, like spade-like hands and feet, what we classically say in cases of acromegaly. So I've written the similar things in the general examination continued. Skin and soft tissue, there is oily, thickened skin with presence of skin tags, presence of acanthosis nigricans, and hyperhidrosis, which is noted over her palms and face. Among the extremities, the broad spade-like hands and feet with soft tissue swelling over the distal extremities and clubbing was not noted. Posture and gait was normal. Spine was normal. Now, as far as vitals are concerned, that was within normal limit, and rest of the examination was also within normal limit. Thyroid gland was not palpable. Now, coming on to the systemic examination, this is a picture of us in the clinic that is doing the visual field testing. In the CNS examination, in the cranial nerve examination, the only noteworthy finding was there was a visual field testing showed bilateral temporal field loss, which was more prominent in the superior quadrants. Rest of the clinical examination of the systemic examination, CNS, was within normal limit. And the rest of the systemic examination, as far as this cardiovascular system, respiratory system, and the that is in cases of the GI, was within normal limit. There was no palpable organomegaly seen in this patient. Should I proceed?
Neurological examination?
Yes, this is the neurological slide of the neurological examination.
Right,
In the
okay.
cranial nerve findings, there was a visual field compromise was there. And now coming on to the provisional diagnosis so far, my case is my provisional diagnosis is residual acromegaly due to pituitary macroadenoma, status post-trans sphenoidal surgery and radiotherapy, currently presenting with clinical reactivation and visual field compromise. Okay. Now, moving ahead with the investigations. So as far as these investigations are concerned, I have divided my investigations into three categories. The first set of investigation, what was done during her index presentation back in 2010, before the surgery. The second set of investigation was the immediate post-op and 3-month post-op investigations. And the last set of investigation, which we did at our center in 2025 April. So starting with the first set of investigation, which is investigation at the initial diagnosis, that is in 2010. Now, in the biochemical that is evaluation, the only significant clinical that is biochemical finding was a higher level of IGF-1 level, which was 605 nanogram per ml. And the growth hormone post-glucose suppression was 59.2 nanogram per ml, which was on the very higher side. That is, so this is IGF-1 is used for the screening, and the growth hormone is used basically for confirming for the confirmation of the diagnosis. Now moving ahead with the imaging.
Can you just explain in one line, no, IGF, because there are many students there. So
Yes, sir.
why IGF is important in acromegaly?
So in acromegaly, the pathology is basic pathology is the increase in the growth hormone. But growth hormone, since it is released in a pulsatile manner from the that is the anterior pituitary, so a single growth hormone level won't be able to that is rule in or rule out the diagnosis of acromegaly in this case.
Right.
So that is why, and since the IGF-1 release from the liver is mainly regulated by the growth hormone, that is, so that is why we take IGF-1 level as a surrogate that is for the screening of the excessive growth hormone activity in our body. And that is why we take IGF-1 for the screening test. And if IGF-1 comes out to be on the higher side of the normal or higher, that is, then we go on to test the growth hormone, that is, and we do a glucose suppression.
And other specific tests, yes.
Yes, other specific tests. Okay. So,
Okay.
sir, can I proceed?
Madam.
Okay, Abhishek.
Yes, ma'am.
Am I audible?
Yes, ma'am. Yes, ma'am.
Yes, you are not audible. Right?
Okay. Okay. So your diagnosis is acromegaly, okay?
Yes, ma'am.
Yes, yes.
Okay. Why have you done this IGF-1? You have already explained. So can you tell me that there is certain situation, which investigations do you want to do apart from IGF-1 screening and growth hormone?
Sorry, ma'am.
What imaging do you want to do?
Acha, imaging. Ma'am, as far as this imaging is concerned, we can do that is the X-rays can be done first of all of the feet. We can do the X-ray to see the heel pad thickness, which is classically increased because of the soft tissue proliferation. We can also see the X-rays of the hand as well, where we can see the spade-like deformity and the arrow sign, which is seen in cases of these patients. Also, as far as this, if we take a lateral view of the skull, we can see the increase in the sella, the sella floor. There is a double flooring of the sella could be seen because of the enlargement in the size of the sella. And what we classically do is that is confirmatory. We do an MRI. We do an MRI, that is gadolinium enhanced MRI. We do that is for the pituitary to see the size of the macroadenoma and before proceeding for the surgery. So these are the clinical that is sets of investigation imaging I'll do in this patient.
Have you done this imaging? What you have described?
Yes. I'm just going to show. Yes, ma'am. This is the imaging which was done back in 2010. That is, I've collected this from the patient. This is the X-ray of the skull, and this is showing the enlarged sella, and the double flooring could be seen of the sella.
What else can you see?
And
what else can you see in this in this X-ray? Apart from this double flooring of sella, what else can you see? What are the other points?
So there, ma'am, there is an size of the sella, that is sella.
Can you comment on the bone
that is
bone
floor
loss
of the sella?
Osteopenia in this patient?
As far as the skull,
I think this is the old X-ray, na?
Yes, this is an this is, ma'am, this is an old X-ray back from 2010. Sure.
You may not get here, but you can get classically the destruction of the clinoid process. You can also see the prognathism in these patients, and also the enlarged sinuses. So these are the classical findings which you can get from the X-ray before doing your MRI. So these are for exam purpose, because nowadays we go directly to the MRI, but examiners will ask you regarding these things. So why you have mentioned about this hoarseness of voice or deepening of voice? Why does this occur?
Ma'am, deepening of voice is there is that is hollowing kind of sound, which is basically due to this enlarged that is sinus sizes are there. So that is why.
So that is I am telling you that this deepening of voice is due to enlarged sinuses, which may be visible if you do a paranasal sinus X-ray. Yes. So what are the other X-rays you have done?
Ma'am, this is the other that is X-ray of the left feet, showing you the increased heel pad thickness. This is I've also collected patient itself. As we can see, there was an enlarged
increased heel pad thickness.
Ma'am, that is.
When will you say that it is increased heel pad thickness?
Ma'am, in male, if it is more than 25 millimeter, and in females, if it is more than 23 millimeter, we say that it is an increased heel pad thickness.
Usually 21 and 18.
21, yes, ma'am.
21 in male and 18 in female. Yeah, there may be variation in both, because these are not
some 21 in male
nowadays.
Yes.
Okay. Yeah. So can you show me the image, MRI?
Yes, ma'am.
Oh, this is the image of the hand.
The X-ray. Yes, this is the X-ray of the hand also. Ma'am, I can see that is in distal phalanx. There is like arrow-like deformities are being present because of this tapering as we go. That is more distally, and there is broad.
Very classical.
And yes. Also, there is like.
And how will you describe the hand itself from the clinical examination, not from the X-ray? If someone says, please describe the hand.
Ma'am, it will be like a spade-like hand, because the fingers will be broadened. That is in cases of and the hand, and the skin would be thick. Like if we palpate the skin, that is, it will be less pliable. That is in case of if we roll the skin, that is, it will be less pliable.
That is typically called doughy feel.
Yes, doughy appearance.
Doughy feel of the hand.
It is the doughy appearance of the hand. Yes,
doughy is not only in the cox abdomen, but here also it is called doughy feel of the hand. Okay.
Yes.
And can you get any wasting in hand of the patient?
Wasting, if there is a compressive, yes. If there is a compressive neuropathy, like a carpal tunnel syndrome, then we can have this thinner
Then among
wasting.
the downstream hand, you may get a thinner eminence wasting. Okay, so go to the MRI.
Now I'm coming on to the MRI. So this was the initial MRI which was done in 2010. This showed a large, well-defined space-occupying lesion with solid and cystic component in the cellar, supracellar, and paracellar region, compressing the optic chiasma. As we can see, it is encasing the right carotid, internal carotid artery here.
You are showing the coronal section. Can you
Yes,
show me
ma'am.
the sagittal section?
Yes, sagittal. Yes, ma'am. I have
In
taken the
coronal
sagittal
section,
section
you
as well.
cannot see properly the optic chiasma. Okay,
Yes,
optic
yes,
chiasma compression is visible very well in the sagittal section.
sagittal section.
And
Yes,
in the
ma'am.
coronal section, if you go back, you go back to the coronal section, so
Yes,
you
ma'am.
can see the these black hole type lesion. These are the two internal carotid arteries in the cavernous sinuses. So you
Yes.
can see that in the left side, actually the tumor is encasing the internal carotid artery. Can everyone see it? The students? These two dots,
Yes,
black
ma'am.
dots, like
Here.
these are actually the internal carotid arteries. And in the left side, there is the tumor mass actually encases the this carotid artery, and this is the probable reason why the tumor is still remnant is there. Residual tumor is there because it was a very difficult surgery. That might be the cause. So please proceed if anyone else have no question.
Then should we proceed?
Yeah.
Okay.
Time is very
Okay.
short.
So this is the okay. Now coming directly to the post-op histopathology.
Just one question, Abhishek, before you proceed. That
Yes,
can
ma'am.
you have any situation where you are seeing that the patient is having all the clinical features of acromegaly, most of them, but the patient's IGF-1 is normal, and the growth hormone is also not suppressed. What are the possibilities?
Ma'am, it could be like it could be an autoinfarct.
Might be.
Okay, and it could be like ectopic could be there. Like if it is the growth hormones.
Ectopic, you will get growth hormone increase even if ectopic.
Okay, ma'am. Okay, so question, ma'am, can you repeat once the question?
Biochemically, it is normal, but clinically acromegaly. So one is definitely the disease is burnt out due to autoinfarct, and the second is the acromegaly appearance, which may occur in insulin resistance.
Yes, it could be pseudoacromegaly. Yes,
Pseudoacromegaly.
It could be pseudoacromegaly, like the feature in
condition.
conditions.
Yeah, the face is very much similar to acromegaly, but it is due to severe insulin resistance. That is a possibility. And what
Like
you are telling
possibility.
that suppose the growth hormone is not suppressed by glucose and IGF-1 is also high, in those situations, if the MRI is normal, then what will be your?
Then it will be sorry, ma'am. Then it will be ectopics.
Yeah, then you should think of ectopic growth hormone releasing hormone or ectopic GH secretion. So you should go for CT chest and CT abdomen in those cases. Although these things are rare, but even if you don't think of the rarer disease, you cannot diagnose it. That is the thing. And sometimes you also get that there is growth hormone is not suppressed by glucose, and IGF-1 is low. So can it happen that IGF-1 is low?
Yes, ma'am, it can happen.
How?
Ma'am, it can happen like since IGF-1
inappropriately low.
Ma'am, since IGF-1 itself is produced from liver, so in the chronic liver disease, the IGF-1 could be down, low, and also in cases of growth hormone, that is resistance, that is in cases of the IGF could be low, and also in cases of severe malnutrition or severe hypothyroidism, that is in cases of conditions like this, the IGF level could be low, that is disproportionately low.
And also uncontrolled diabetes.
Uncontrolled
so
diabetes.
These things may happen because in acromegaly you may get associated diabetes. You may get compressive hypothyroidism due to compression of the pituitary thyroid trough. So liver disease may be associated with it. So these things can happen. And in those cases, you may not get low, it may get inappropriately low IGF-1 in spite of non-suppressed growth hormone. Okay, so proceed.
Okay, thank you, ma'am. Now coming to the histopathology, the reports were consistent with plurihormonal pituitary adenoma. This is the report of the histopathology which I've attached. This was in that is 2010. Now coming on to the second set of investigation, which is the post-op imaging. This is the post-operative day 1, the MRI brain was done, and you can see there is a distorted anatomy around the sella region because of the post-surgery being done. Now, the growth hormone levels post-operative day 1 was 12.7 nanogram per ml. It was still detectable, and this is basically indicating towards there is a that there is a residual disease still present. MRI brain was done 3 months post-op, which showed residual tumor in the right paracellular region and cavernous sinus. And the growth hormone level, which was done 3 months post-op, basically showed a level of 28.6 nanogram per ml. So the growth hormone was, that is in case of, showed an increase from the post-operative day 1. So she was planned for adjuvant radiotherapy. This is the documentation of her adjuvant radiotherapy which she received. She received total of 54 in 30 fractions. Post radiotherapy, her growth hormone was 5 gram per ml. Now, when she presented finally to our clinic, this is the recent workups which we have done. Yes, these are the recent workup, ma'am. That was done in our clinic at recently. So in the recent workup, once again, the IGF-1 levels are on the higher side, 654. The growth hormone of 2-hour post-glucose suppression is 32 nanogram per ml. So these are again suggesting towards, okay, there is a residual tumor still residing. So we went with the imaging. Once again, we did the imaging, that is lateral X-ray of the feet we did. And here, even though the heel pads appear thicker, but it is much, much lesser than what we saw in the initial, that is in cases of this 2010 X-ray. And then we went directly to the MRI brain, which showed the encasement. There was a residual tumor, which showed the encasement of the right cavernous sinus and cavernous segment of the right ICA. As we can see in this image, that is on the right side, there is still some amount of residual disease which is present in this patient. So this is the that is workup which has been done so far. And now we did the perimetry. Yes, ma'am.
No, just a few questions which you may be asked in your exam. That what are the neurological complications of this patient and what are the cardiovascular complications of this patient? Just
neurological
one or two
complications.
sentences.
Neurological could be starting from headache. It could be even seizures, as we have discussed, or it could be the cranial nerve involvement, that is 3, 4, and 6. It could be an abductor palsy, could be there. Also, there could be proximal
Don't go
myopathy.
straight to third, fourth, sixth cranial nerve. First, tell about second cranial nerve.
Second cranial nerve, yes, sorry. Yes, ma'am, I've already said the third, second cranial nerve. There could be acuity problem, could be there. There could be a problem in the visual field, as was classically seen in this case. There could even be color, that is red color, that is blindness, could be seen in this patient. And
what is the classical visual field defect?
Visual
and in
field
how many
defect,
patients it is seen?
Ma'am, classical visual field defect is bitemporal hemianopia, which is being seen. And it is seen, ma'am, I cannot...
in how many percentage of cases you see it? Bitemporal hemianopia?
Ma'am, I'm not sure about the exact percentage.
It is around 50%. In another 50%, you may not get it. There may be scotoma, may be monoocular blindness too. Because actually, we think that the chiasma is fixed over the pituitary, but it may be prefixed or postfixed slightly. So if the chiasma is slightly prefixed, what will happen? It will the pituitary, enlarged pituitary will compress the optic radiation. So different types of hemianopia you may get here. As for example, here you are getting superior quadrantic hemianopia, I think. And if it is postfixed in 5% cases, then it will compress on the optic nerve. So you may also get monoocular blindness. So these are not, everything is not 2 + 2 = 4 in medicine. So these variations may also happen. So what are the other neurological manifestations?
Ma'am, other neurological as we have said, the 3, 4, and 6 cranial nerve, that is the palsies can be there. And also proximal myopathy can be there. There can be compressive neuropathy, as I've already said. So these are the most neurological findings which are seen in these patients. And as far as this cardiovascular, that is in cases of the burden is concerned, there is basically the most cases of mortality are because of this increased cardiovascular risk, because of this left ventricular hypertrophy. There is diastolic failure. So there is heart failure with preserved ejection fraction. And also there can be, that is cardiomyopathy, and the risk of arrhythmias are increased. And also there is basically persistent hypertension, is basically uncontrolled hypertension can be present in this patient. So this is responsible for the increase in the severe risk as well as the cardiovascular mortalities in these patients.
Okay, so as you have told that there is some mortality. So what are the other causes of mortality? One is definitely the commonest cause of mortality in these patients is cardiovascular death. Second?
Ma'am, second could be due to the if there is a respiratory failure due to severe obstructive sleep apnea could be there,
Very good.
or even the severe obstructive sleep apnea can ultimately lead to right heart failure, and also there is pulmonary hypertension could be there. Other causes could be malignancies. That is like the most common malignancy is the papillary thyroid cancer, which is that is in the scene, or the colonic cancers. That is in colonic polyps are more. That
Colonic
is
cancer is very important. So you have
very
to do at least 3 to 5 yearly colonoscopy in
colonoscopy is
this
done.
patient
Yes, ma'am.
to
With
exclude
5
colonic CA. So this is very
yes.
important.
And
Okay. So
other
what else investigation you want to? Okay. Someone is asking question, I think. If no, then what else investigation you want to do in this patient?
Mr. Dharmishta, it was excellent discussion going on. I just want to add very rare one neurological finding, though it is not very common. You can get it in case of your acromegaly, very sometimes the nerve thickening of nerve.
Okay.
So if you
Yes,
palpate
sir.
the nerves, like that of a very rare conditions, where you in amyloidosis, you get in leprosy very commonly,
Leprosy, yes.
neurofibromatosis, and acromegaly is one of the conditions, because you have mentioned everything. So only rarely you can come across with a peripheral nerve thickening.
Yes, sir. That is a part of the generalized organomegaly and generalized IGF-1 mediated increase
Yes, it's
in
to be mentioned. It's to be sometimes some examiner asks.
Yes, sir. Thank you, sir. Okay, so what are the other investigations you will do in these patients?
Ma'am, other investigations I'll look for the other hormonal assays to look for any deficiency or the possible stock effect that is in cases of these patients. Apart from that, I'll also go for a baseline, I'll say echocardiography and a colonoscopy would be done in these patients to look for that is in cases of to have a look on the that is comorbidities associated with these patients.
Any other hormonal test and biochemical tests?
Hormonal test, ma'am, all the that is prolactin, that is in case
Prolactin you should always do, and other hormones too.
Other hormones will also will do.
Other pituitary hormones.
For,
because
yes,
there may be compressive hypopituitarism.
hypopituitarism.
So it's very
Yes,
important.
Yes.
And any biochemical test, the most important biochemical test which you should always do?
Along in this case, that is sugar. We'll that is check the sugar.
How many percentage have got IGT and how many percentage have got diabetes?
Diabetes is present in around 25% of the patients of the acromegaly. That is in cases of this. 1/4 of the patients.
There is a big term that in most of the endocrine cases, there is 1/3 cases are diabetic, mostly. And also IGT you can get up to 60% cases. Okay. And there are certain other biochemical tests are also sometimes important that these patients may have hypercalcemia and hyperphosphatemia both.
Hyperphosphatemia both, yes, ma'am.
Yeah, both can happen. So these things are other biochemical parameters which you may get abnormal in these patients. So quickly going to the management.
Yes, ma'am. This is the like this
about transnasal transsphenoidal surgery. Okay.
Yes.
So
yes, ma'am.
This domain. So what will be your preparation before sending the patient?
And first
Because
initial preparation.
Yeah.
My initial preparation or deficiency and to actually address the situation, like the patient should be in the euhormonal state, and also I have to take care of any cardiovascular risk if it is persisting in this patient, or any airway obstruction is that is airway risk is being there. So that is the clinical that is preparations I'll do. That is first up in this patients.
Control blood sugar of the patient. You control hypertension
blood sugar,
of the
yes, ma'am. Definitely hypertension of the patients, and
you should always replace the hormones. Particularly if you don't replace cortisol, then the patient will go to adrenal crisis during if there is compressive hypopituitarism. You should also replace your thyroid hormone. Otherwise, the patient will not recover from anesthesia, and you will also examine the anesthetist will assess the patient beforehand, before intubation, because there are mucosal, laryngeal, mucosal hypertrophy. So there may be difficult intubation. So these are the points which are important from our physician's point of view, because the other things that are done by the surgeon. Okay. So now the surgeon has operated and sent the patient back to you. So what are the post-operative situations which will you monitor? When the surgeon will call you, that these are the problems the patient is facing. So what are the problems that the patient may face in post-operative period?
When post-operative period, the most common problem it can we can encounter is there could be a transient or there could be a permanent diabetes insipidus could be present. The first thing is there can be that is situations like there could be hypopituitarism can be present. Also, that is in case of immediate
After
post
surgery, clinical
after surgery.
panhypopituitarism.
Yes,
Just
clinical
for DI, you
panhypopituitarism.
have correctly mentioned DI, but I'm just adding a point. There might be a triple response, like trauma.
Yes.
Then maybe initially there is DI due to transient jeopardization. There is ADH secretion is impaired. Then maybe there may be syndrome of SIADH may supervene after DI, and then again there may be permanent DI. So these things can happen. And another thing you have correctly mentioned that after surgery, there may be new onset panhypopituitarism. So these things we have to keep in mind, particularly the sodium. Doing sodium is very important because of this triple response. Because sodium will guide us. We cannot do ADH all the time. That will guide us whether the patient is having DI or the patient is having SIADH, apart from the urine output of the patient. So, and there may be certain other local problems too, like epistaxis, like abscess, like meningitis.
CSF leak, meningitis, yes.
CSF leak is very important. Yes. CSF leak is very important. So, what are the other modalities of therapy? And one thing I have forgot to mention, because in your preparation, when there is very extensive tumor, then before surgery, apart from hormonal replacement and apart from controlling your sugar and blood glucose and hypertension, you should also may do a medical debulking of the patient, because that will decrease the risk of that will shrink the tumor, and that will decrease the risk of having complications like injuring the important structures like carotid artery. You have seen in this MRI. The tumor is so close to carotid artery. The tumor is so close to optic chiasma. So if you do medical debulking, then definitely the outcome of the operation will be good. So now what are the modalities of therapy? Definitely I'm talking about radiotherapy and medical therapy.
Ma'am, in the radiotherapy,
we are at the last part of the discussion.
Ma'am, in the medical therapy, we can go for a conventional radiotherapy or even the stereotactic radiotherapy if it is very close to that is in case of important structures. In the medical therapy, we have that is in case of what we commonly use is the somatostatin receptor ligands. What we have available here is the octreotide, lanreotide is there, and also another option is pathirotide, that is in cases of the case that is can be used. Apart from the somatostatin
is there also.
LAR, yes. Octreotide LAR is there.
LAR is also there.
LAR is there. Yes.
This is available in our hospital also.
Yes, ma'am. This is available in our hospital.
We are bringing for this patient octreotide LAR. These are the long-acting ones. We can give it monthly, although it is costly, but railway is providing. So we can have these options if the patient can afford or the institute can afford. Okay.
Other options of medical is dopamine agonists. We have cabergoline and bromocriptine can be given in these patients, and also we have growth hormone receptor antagonists like pegvisomant is a proposed that is in cases of the we have the medical therapy in this patient. So this is the common group of drugs we use in this patient.
So after giving pegvisomant and after giving these medical therapy, what will you monitor?
Ma'am, I'll monitor the biochemical hormonal monitoring will be there. There will be clinical reassessment of the patients. I'll also monitor the that is an 6 monthly or an that is annual MRI will be done to check the assessment, and also I'll do a clinical and a perimetric visual field that is in cases of the assessment of this patient as well, and also will monitor for the any possible side effects.
Yes, side effects. And one thing you'll remember that whenever we are giving pegvisomant, then actually, basically, this is acting on the growth hormone receptor. It is growth hormone receptor antagonist. So growth hormone will not be decreased in these cases. Only IGF-1 will be decreased. So don't be afraid of the thing that I am giving pegvisomant, but it is not decreasing. This is the IGF-1 will be the monitoring tool in these cases. So I think, just the last question, which is asked in the clinical examination, is that what are the signs of disease activity? I could have asked this question previously, but I have missed it. What are the signs of disease activity in a case of acromegaly?
If the signs of disease activity could be features of the not regression of the soft tissue, so soft tissue enlargement, that is the oily skin, that is in cases of the increased seborrhea. Also, arthropathy could be one of the features of the signs, and the uncontrolled diabetes, obstructive sleep apnea. Features like this are that is in cases of suggestive of there is an active disease going on inside that is with the patient. And also, if there is mass effect like headache can be there, and that
Yes.
other that is
Headache,
cranial
fever,
nerve involvements
progressive
could
visual impairment, seborrhea,
progressive visual seborrhea. Yes, ma'am.
increasing
Seborrhea.
size of the ring and stool, yes,
Yes, ma'am.
and new onset hypertension and diabetes. So these things are the because the bony configuration that doesn't change. Only the
Change.
soft tissue is regressed. Bony configuration that doesn't change. So with this, we can assess whether the disease is active or it is just
Yes.
disease which are shown. So I think you have 1 or 2 slides more now.
Yes, ma'am. Just few slides
Can you
left.
change the slide?
Yes, ma'am. This was the perimetry which was done. Like right eye showed a temporal field effect, which was
We
more
have to
prominent.
wind up, Dr. Mukherjee.
Yes, ma'am. Yes, sir. It's
We
almost
have
done.
to wind up.
Yes,
This
yes.
is the last slide with the proposed management in this patient, as we have already discussed. Octreotide LAR, 20 milligram
Yes.
intramuscular
And
every 4
you
weeks.
just show the last slide, how the patient.
Yes, ma'am. This is the last slide of the patient, which has changed appearance gradually. The initial.
So this is the patient's appearance, which changed over the years. So I think this is self-explanatory how disfigurement acromegaly can cause. So I think if any other question from my side, I'm just winding up because it's too late already. Any question from anyone else?
Please check the chat box if there is any.
Yes, sir. This is the sir. Am I audible?
Yeah.
So this is the last slide of the presentation, showing you the patient. That is, this is the during her puberty. That is in cases of the first image, and then that is the second image of the middle one is during her first surgery, and this is the last image, which is when she has presented to us. And as we can see, the gradual changes in her facial features, which are visible over here. So concluding my that is in case of presentation. Thank you so much for your patience hearing.
Thank you. If there is any question in the chat box. The most important cause of was to stop antithyroid. Oh no, these are no. Is there any question from anyone, please? If it is no, then I think that it's already very extensive.
Okay.
There were 3 cases.
So,
And there were some
Sormista, can I
logistics
make one
also
question?
Yeah,
Sormista, can I make any question?
Yes,
Yes,
please.
why there was no progression of clinical symptoms for many years of this patient? Is there real any explanation? The patient has got a problem for 15 years, and in between few years, patient was in the quite in the stage of no progression of the disease. What is the real explanation? Is there any such?
So on the retrospective analysis, I can say that the patient was operated, and definitely there was residual tumor because of difficult situation, and their patient's radiotherapy was also done. But there may be recurrence of the symptoms because of recurrence of tumor. That may happen at any time. There may be there are 2 things. One is the residual tumor, and second is the recurrent tumor. So both of these can happen. So probably there was some residual tumor because the growth hormone was never normal after glucose load in these patients. So probably there was some residual tumor, but the patient's symptoms significantly improved after operation and radiotherapy. But probably there is again recurrence, because in the last MRI we are seeing that again there is some increase, because there were 3 MRI, only 2 MRI are shown. So after the surgery there was 1 MRI, and the recent MRI where it has been seen that from the second MRI, the third MRI has got some increased growth of the tumor. So probably not only residual tumor, but there is also recurrence of tumor. I think that is the probable explanation.
There is no headache. Still, do you think that the patient
No,
may have
that is
clinical symptoms and signs with so much extensive tumor? Is it possible? No headache and with this presentation?
normal
The
situation.
presentation was
Actually,
there was
these
no
patients,
headache. Yeah.
But we are honest in their history because
Yes, sir. There was
really
no
the
uh,
patient
there
gives
was
the
no
history.
complaint of
What
headache
can
from
we
the
do?
patient
So
point of view.
that is my question also.
Although we ask
No complaint
repeatedly,
of
he
headache,
doesn't
having
do.
a so much large tumor, having so much SOL-like presentation without any headache. That is my question also. Is it very easy, common to find it or not?
This is very rare.
This
Very
is rare.
uncommon. Very uncommon. Might be what happened in 17 years back that she forgot, and now the tumor size is not that big. So might be that so the headache is not that prominent. But initially there should be headache. But this patient did not complain. So we had to stick to the patient's history. What else we can? That is
Madam,
it. But
what
definitely, I think that there should be a history of headache.
Dr. Mukherjee, what is my interpretation is the growth was very slow. That's why the without any
Yes.
intracranial tension rise, the tumor got so much expensive volume, but patient didn't have any headache. It was very slow. That's why it progressed
Yes,
for
yes, yes.
17 years without any
That's a
symptom.
very good explanation. Yes, yes, yes. Probably.
Is the carotid artery going to be damaged by radiation in this patient?
So that is
Is
why
it
we went
possible
for
that the radiation you are giving, is there any harm to the carotid artery while giving a radiation in and around carotid arteries? Is it going
Usually
to
it is
harm,
not.
doing more fibrosis? Yeah.
Usually no. Usually no. And radiation has been done many years back.
radiation was done
Nowadays we are
like
thinking of
in
medical.
yes. And also that was stereotactic radiotherapy was given to the patient. This was well localized.
Is stereotactic is really a stereotactic? Is it very easy to put only the tumor cells are going to be destroyed by radiation?
No, sir, I don't think.
Is it that true? Okay.
No, sir.
So thank you. Bye.
Thank you, sir.
Thank you for the comments.
Thank you, Sir Mister. Now I think we should come to an end, and I will request Professor Satya Gaguli for
Thank you.
Vote of thanks.
Thank you. I am giving vote of thanks first to Shormistha and her team. But my personal opinion is that this lecture should be divided in 2 days. For one day, it
But it will be a big issue if 3 issues are kept.
and
But
because
anyway,
you are very interesting and very educative. So without making any further comments, and also I thank the 3 young PGT. They have prepared very much, and so they have a very bright future. So thyroid and pituitary are the 2 most important glands. So these things should be discussed in 2 days. Thank you. Thank you, everyone.
Thank you, sir.
thank you, everyone. My sincere apology for the initial part of Wi-Fi issue, and I am really privileged to chair this master class. And thanks to API organizers for giving chances to my PGTs and for me as a teacher. And I would like to do such classes in future also. So thank you all. Thank you all for inviting us.
Okay. Thank you. And we conclude here. Partho, do you want to make any Partho Kormokar?
Yes, I'm here.
Next class?
Regarding next class, we will give our information in WhatsApp.
Okay.
Okay.
Thank you.